Hi, welcome to Bone and Soft Tissue Neoplasms at bstneoplasms.com. This is Dr. Bhavin Jankaria, and here we are with our 49th case titled Femoral Levels. So, this 5-year-old presented with pain and swelling in the left distal thigh. Those are the x-rays, the frontal at the lateral, the MR. And you can see there are four sequences. That's the CT. And you have the histopath, though this is of a different patient. The images were similar, just misplaced the images of this patient. And these were the choices that you had. So let's go through the case, right? We have a permeative pattern. There is a wide zone of transition. There's a sunray appearance. So this is a very aggressive pattern of periosteal reaction. Here's the Codman triangle. And more important, we have a lot of new bone formation or osteoid with abnormal soft tissue. So clearly, we have a malignant tumor with osteoid. And so that itself should tell us on the X-ray that this is an osteosarcoma. Then we have extensive fluid levels. So these fluid levels in the setting of what looks like an osteosarcoma on the X-ray. You can see the osteoid on the MR here. This is how we can identify osteoid on the MR. You see very dark areas. So this clearly then would tell us that you're dealing with a telangiectatic appearance within an osteosarcoma, right? Now here, the CT just shows that so much better. That's the sunray appearance, that's the osteoid, that's your Codman triangle, that's the abnormal soft tissue, and you can also see some fluid levels on the axial images. Now, clearly, we've already deduced that this is a telangiectatic osteosarcoma, but let's look at the others. I think the commonest issue occurs with aneurysmal bone cyst because that also presents with fluid levels, but, and I'll discuss this later in the piece as well, the fluid levels pretty much involve the entire lesion, and they don't get broken up and you don't get solid elements within. And we discussed this as case 24 here. You can see this beautiful distal humerus ABC. Clear cell chondrosarcomas are not that common, but you do, and they're more mimics of giant cell tumors. So you get them as epiphyseal lesions, distal femur, proximal tibia, sometimes proximal humerus, and uh, they may show fluid levels and they may show these solid areas within, but usually the first diagnosis is giant cell tumor, and then you get a clear cell chondrosarcoma on the histopath. Ewing sarcoma is a different tumor entirely, and there's a whole discussion in case 8 which you can go through. And the histopath shows both osteoid and abnormal cells. So that's osteosarcoma, and there are telangiectatic areas within as well. So that's the answer, and three-quarters got it correct, which is terrific. So telangiectatic OGS is a high-grade neoplasms. It is it's about 2 to 12% of all osteosarcomas. Mimics ABC more than GCT, typically in the 15 to 20 years, and the commonest site is the distal femoral metaphysis, followed by the others that you can see here. And as we described on the X-ray, most of the times you get an aggressive lesion. Very rarely do you get a narrow zone of transition. Aggressive periosteal reaction, extraosseous extension, and osteoid and MR. There's abnormal soft tissue. P2 dark areas if there's osteoid fluid levels, etc. So this patient, you have a distal femoral lesion. The articular surface is not involved, so you're not going to mistake this for a giant cell tumor. You have a moderately wide zone of transition along the medial aspect. And in fact, if this had reached the articular surface, you would still say this is a giant cell tumor because GCTs don't always have narrow zones of transition. But there is irregularity here along the lateral cortex as well. Don't see it very well on the lateral, though you do see it here once you know that it's there. And then on the MR, while you do have a fluid level, you have all of this solid component here. So this needs a biopsy for sure. And then this was a telangiectatic osteosarcoma. And note the complete absence of marrow edema in this patient. So these are the ones that get mistaken for ABC either on MR or sometimes even on biopsy if it doesn't sample the correct area. And that's where often there is a conundrum of whether this is an ABC or a telangiectatic osteosarcoma. But once you have this pattern, aggressive lesion, wide zone of transition, osteoid, extraosseous extension, even on the X-ray, and then you see that on the MR, even if there are such fluid levels, we won't have a problem calling this telangiectatic osteosarcoma. And this one's a large blowout. You see fluid levels. Remember, even ABCs can sometimes blow out completely, but we also see solid areas within, and there is a lot of extraosseous extension. This is also a biopsy-proven telangiectatic osteosarcoma. And sometimes you can get them as surface lesions as well. And you can see a surface bone-forming lesion here. And remember, last time I talked about a periosteal osteosarcoma, and this is pretty much that. And you can see solid components and fluid levels. And this is a surface osteosarcoma. So fluid levels can be benign, as in primary ABC and secondary ABC. So secondary ABC can occur in all of these tumors. And then you can get fluid levels in telangiectatic osteosarcoma, clear cell chondrosarcoma, and rarely metastatic disease. So here's fluid levels in a chondroblastoma, fluid levels in a giant cell tumor, fluid levels in a patient who has fibrous dysplasia. These are quite easy to figure out. They just involve a small part of the tumor, and then you use the rest of the findings to characterize the tumor. Uh, The article by Zishan and Asif Saifuddin in skeletal radiology has become a very kind of a landmark article for differentiating ABC from telangiectatic osteosarcoma. So on the X-ray, you get typically ABCs have this appearance. So if you see a wide zone of transition, you see periosteal reaction, if you see a large size, then you think of telangiectatic OGS. If you see a soft tissue mass, if you see fluid levels interrupted, if you see solid components within the fluid levels, thick septate, then you would think of telangiectatic osteosarcoma. So here's a classic ABC. You see fluid levels occupying the entire lesion here. But here you see fluid levels, but you see solid components here. You see osteoid here. It's an aggressive lesion. I don't think we would ever mistake the X-ray for an ABC. So if those who report MRs only without looking at the X-rays can get into trouble. And that did happen with this patient where a colleague of mine called it an ABC on the MR, which they would have never done if they'd seen the radiograph in advance. So it's a rare osteosarcoma variant characterized by the presence of fluid levels on MR. And when the findings are typical of a high-grade malignant neoplasm on X-ray and MR, then the diagnosis is easy and the fluid levels only tell you that it's telangiectatic osteosarcoma. Sometimes the differentiation from ABC may be difficult. So this was the case. That's the index. Now we have 49 cases and I think a few lectures. My WhatsApp channel, other sites and cases, I did the pseudomiliary appearance at CT chest review, sub 4 millimeter lung biopsy at CT biopsy. Friend of mine had this accident and became a backseat bullet, so I wrote about this, and that's the heart of stone at cardiac MRI. You know where to comment, email, subscribe, etc. And thank you for listening to this.